have Major Erik DeSoucy from the United States Air Force here to talk to us about some military experiences, I think, with traumatic injuries. So, Major DeSoucy, thank you.
Thank you. Like Dr. Pevic said, this is a topic that's somewhat near and dear to my heart, given my previous background with pararescue. And prolonged field care itself has kind of become a hot topic within military medicine as we shift our focus from one battle space to the next. So my personal background, currently I'm in the joint combined surgery program here at UC Davis in joint collaboration with David Grant Medical Center. Prior to my coming here, I was 3 years the flight surgeon at the 48th Rescue Squadron at Davis-Monthan Air Force Base, where I had the opportunity to work with some of the most well-trained, motivated first responders that you'll ever meet, the pararescuemen. Had a couple deployments and numerous hours of flying time transporting ill and injured both service members and local nationals throughout Afghanistan. So a couple of disclaimers. There's always a disclaimer with the Air Force or the military in general. So I do not directly represent the U.S. government, the Department of Defense, or the United States Air Force. But a lot of the things that we're talking about are being discussed and investigated within the military. And in general, any medics that are listening to this, either here or in the future off of YouTube, just remember that any of your local protocols really should proceed and take precedence over anything that I say here, because in the end, you have to follow what your medical director says. So I'm going to take you through a couple of cases, two case scenarios. One is military, one is civilian, one is real, and one is something I made up. So the first one, we can take you to 2013 when in South Sudan there was becoming an uprising. There was an attempted coup, and the local rebels started fighting. So the U.S. Embassy decided that we need to clear out our embassy. So it was early in December, and at approximately 10 o'clock in the morning, we attempted to perform a non-combatant evacuation operation. And the U.S. Air Force sent 3 CV-22s loaded up with a special ops crisis team. And during their initial attempt to land, they came under small arms fire, and all 3 aircraft were damaged during that attempted infiltration. On one of the aircraft, 4 service members were injured during that initial attack. The patient injuries, you can see here, so 4 patients. There was 3 gunshot wounds, 1 shrapnel wound, some with significant amount of bleeding, a lot of extremity injuries. The initial treatment, the patient number 4 was actually a Navy SEAL corpsman, and he managed to treat patients 1, 2, and 3. Patients 2 and 3 got tourniquets, and a manual pressure was applied to patient number 1. And the first 3 patients also received analgesia with fentanyl lozenges, so a little lollipop that you can tie to the patient's thumb, and they can suck on it until they pass out, and then their thumb falls away, and so they don't overdose. Due to heavy damage to the aircraft, they had to divert to Entebbe International Airport in Uganda instead of the planned airfield, which was in Djibouti. And so the patient number 4, the Navy SEAL corpsman, was able to both triage, treat, and then relay the information from those patients onto the forward medical element. Upon arrival, it took about 75 minutes to get to Entebbe International Airport, and they were met by a slew of military personnel, so additional pararescuemen, a flight surgeon, some medical technicians, a PA, really a joint collaborative force that was able to take care of these injured patients. They were then offloaded from the CV-22s into a converted van, and now this is not the converted van that most of our attendings are probably thinking about, but something that probably looked more along the lines of this. So nothing very high-tech, not really an ambulance per se, but something that can get a patient from one aircraft to the next. So the treatment they received while they were at that airport, you can see here. So patient number 1 was in class 3 shock, received TXA and a couple units of whole blood that were actually procured from the walking blood bank at that forward medical element. Patient number 2 showed evidence of class 2 hemorrhagic shock, got a second tourniquet and some combat gauze application. Patient 3, even though he had a tourniquet on, he had a palpable pedal pulse, but since the hemorrhage control was adequate, they left that as was. And then patient 4 injuries weren't significant enough to require additional treatment, and he could wait till the next level of care. So a U.S. Air Force C-17 was then retasked away from whatever it was supposed to be doing and redirected to transport those 4 patients. So again, they transloaded those patients from the airport into the C-17, and they departed around noon local time. And during the flight, they were able to also give patient 1 a femoral block for pain control. He otherwise remained stable. Patient 2 got some ketamine and a bolus, and patient 3, because of Versed and ketamine, became a little somnolent and required some respiratory support. They arrived at the next level of care in Kenya approximately 4 hours after the initial attack. So, initial attack, transloading from 2 different aircraft, and then taking a 45-minute drive through Nairobi in order to get to the emergency department where a team of surgeons and anesthesia personnel were waiting and available. So a lot of different transitions of care, a lot of different skills that were used that you wouldn't necessarily see on a typical civilian call for a patient. So here's just a map of where they were in Juba. Supposed to go to Djibouti, but that no longer became an option when the aircraft were damaged, and we now had survivors that needed to get to a higher level of care. And then they were redirected down through Uganda and finally to Kenya. So being able to kind of make fluid changes to your plan and being able to use whatever resources you have available to you. So let's kind of bring that idea home. So oftentimes we don't think about prolonged field care in a civilian circumstance because we are in usually large population centers where help is literally a 15-minute ambulance ride away. But let's think about if we were somewhere else. And this is someplace actually fairly close to here in Sacramento. This is up near Tahoe in Desolation Wilderness. And again, this is something I made up. A trio of hikers are en route to Silver Peak. A landslide or a rock slide is triggered around 3 o'clock in the afternoon, and 2 of those hikers are injured. So the uninjured hiker just happens to be a former special operations medic, and he has a basic first aid kit at his disposal, as well as a satellite phone, and they call for help. So help arrives about, so the patient injuries, so hiker number 1 is a 30-year-old man, crush injury to the right leg and some chest trauma. The medic provides an improvised splint to that right leg. Hiker number 2, 28-year-old woman, she has a fractured pelvis, an open arm fracture and some pulsatile bleeding. She gets a tourniquet and a jacket wrapped around her waist in order to maintain pelvic stability. So rescue arrives about an hour later. The local rescue comes on a helicopter. They hoist 1 person in with some additional medical supplies. And everything's going to be great. We're going to high five. We're going to get you out of here. But unfortunately, the hoist malfunctions. So hoist malfunction requires the cable to be severed. There's no available bird to come back and pick these guys up. We have to actually repair the hoist before they can attempt another extraction. And oh, by the way, there's thunderstorms expected in about 1 to 2 hours. So treatment on the ground. So we've now transitioned from initial care. Now you've got an additional provider with some additional medical equipment. Hiker number 1 ends up needing some needle decompression for tension physiology. The right compartments of the leg are getting tight. We're treating pain. Hiker number 2, pale, disoriented, probably from blood loss secondary to her pelvic fracture. Gets IV access, a saline bolus, and then a reassessment of her tourniquet. So finally, those thunderstorms clear out. The thunderstorm rolls through. The party shelters inside the tents. And so you're making use of whatever you have around you to protect yourself and the patient. And then they finally pass. You make contact with base, but unfortunately, we don't have night flying capability. You're going to have to hang on to these patients for an additional 10 to 12 hours. So in your mind, start thinking about what would you do. For hiker number 1, how do you prioritize these things in an environment where you just don't have the resources that you really want? So do you place chest tube because you're constantly having to do a needle decompression? Do you decompress the compartments of the fasciotomy knowing that muscle will probably be dead in about 6 hours? How do you prioritize your fluids? Again, you only have a limited capacity of fluids available to you. And then for hiker 2, same sort of deal. How do you take down that tourniquet and see if the pulsatile bleeding has resolved, knowing that whatever's distal to that tourniquet is going to be compromised? And how do you manage your fluids? What are your endpoints? And do you have the wherewithal to bring antibiotics with you to treat this open fracture? In other words, how do you save life and limb in a resource-constrained environment where evacuation is not an option or it's not going to be timely? So that comes to defining the problem. So let's define prolonged field care. Within our last few conflicts, and again, these are still ongoing, but there's been various, swells and withdrawals. We've been primarily in Iraq and Afghanistan. You can see the size of Iraq and Afghanistan compared to the eastern seaboard. But fairly reasonable as far as, if you had to take a flight from DC to Indianapolis, it wouldn't take you too long. Compare that now to what we consider the tyranny of distance. So the distances that we'll have to fly and travel if we're fighting terrorist groups within Africa, for example. It's no longer, as Secretary of Defense Robert Gates put in 2009, we're no longer looking for that golden hour. We're now looking for the golden day. And then you also focus on other areas where we might be involved in the future. The Pacific, again, huge expanse, large area to cover. How do you take care of injured patients, ill patients in this environment? So the current paradigm within military medicine, a lot of it revolves around TCCC, so Tactical Combat Casualty Care. And that's broken down into 3 different phases. The first phase is care under fire. So returning fire, getting to cover, and then stopping any sort of extremity hemorrhage that's going to cause the patient to die within the next few minutes. Tactical field care is then followed, which is doing your primary survey, so evaluating the entire patient, and then patching up and fixing whatever you can as far as treating life threats and treating wounds, that sort of thing. And then that's supposed to go on to tactical evacuation care. So prioritizing your patients, kind of racking and stacking, saying, okay, this person is Cat Alpha, he needs to go first. Packaging them for transport, and in many cases within the military, actually traveling with that patient to the next level of care, providing care en route, especially if you're getting an aircraft that's coming that doesn't have necessarily a medical capability, like, for example, a dust-off or a Pedro bird. But what happens when your evac is not timely? What happens when your mode of transport looks like something that you commandeered from the WHO? What happens when your area of responsibility is this huge continent with a lot of unknowns, with a lot of barren desert wasteland, with the potential for dust storms that are going to affect not only the patients, the operators, but also the equipment that's going to get you in and out of those locations? And then what if literally you're on a deserted island where you're out in the middle of the Pacific and you may have minimal evacuation options? So the military medicine paradigm, again, the perception has up until this point been that military medicine is TCCC. You go through this algorithm and the patient gets home, everybody high fives, and it's great. But that is only when you're able to provide medicine within the box. So within these normalized protocols that allow for, that are allowed by a robust evacuation system. So in the current model, we basically go from TCCC to an EMEDS via helicopter, from EMEDS to launch stool by C-17, and then finally on to Walter Reed Medical Center. But that has been the reality for the last 10 years, but with the drawdown in both Iraq and Afghanistan, for example, Balad Air Force Theater Hospital closed in 2011, so you take away that piece, and now you have this big gap between TCCC and getting the patient to the next level of care. The other thing we have to consider is things like non-TCCC events. So these are the things that will occur during just being at an airbase. You might have rollover accidents. You might have people that are falling, getting injured on the job. Burns, electrocution, ACS. A lot of our contractors, people that are 50, 60 years old are out as contractors and end up getting heart attacks. These are the things that keep medics awake because, in general, we don't have a protocol for these situations. There's very little within our book that deals with anything other than trauma. And so but the thing is to note about this, and the way this kind of ties into civilian care, is that these are all common to EMS. These are runs that our EMS and first responders make on a regular basis. So the actual NATO definition of prolonged field care is field medicine care or medical care applied beyond doctrinal timelines, so longer than you plan to be there. Usually by a special operations medic, a combat medic or higher, in order to decrease patient mortality and morbidity. And you're doing this while utilizing limited resources, and you have to sustain the patient. You don't give up on them. They either arrive at the next level of care or they end up dying in the process. A lot of this has correlation to some of our other civilian institutions, such as Advanced Wilderness Life Support, where these are the curriculum objectives. So anybody who's ever done this course, you go out and it's very interesting. You get to do a lot of the splinting, improvised litter carries, that sort of thing. But you're trying to teach them how to assess the patient and support them until definitive care can arrive. And you're oftentimes managing both medical and trauma emergencies with no really defined evacuation. So you're doing this until evacuation is available, and also teaching you how to prepare for evacuation. The World Health Organization has also, as part of their violence and injury prevention campaign, has identified within their pre-hospital and trauma care system documentation, there's a little blurb in several 100 pages of document where it mentions if in remote areas, which in Africa there are a lot, that we need to make sure that we're teaching local healthcare providers to stabilize patients so that they can survive and endure through the rigors of long-distance transport. So let's define the problem from an epidemiologic standpoint. Now, I'll admit this is a shameless plug for some work that we did recently that was recently published in Journal of Special Operations Medicine. But when we went into this looking at prolonged field care and trying to identify who these patients are, what they end up needing, I think we went into it thinking we're going to find just a bunch of battlefield injuries. But that didn't necessarily end up being the case. About a third of the patients that we identified as having received prolonged field care actually came from either a civil or a humanitarian search and rescue mission. And those, again, are a variety of injuries, motor vehicle accidents, abdominal pain, falls, lacerations. But while maybe not the bear mauling, these are all very common to civilian EMS. And what factors do we identify that contributed to those prolonged field care? So in about a third of the cases, it was literally because there's enemy in the area and they're shooting at us. So you get that one, okay? We get it, you were delayed. Weather, mechanical issues, the lack of night flying capability, these are all things that can affect civilian institutions or civilian trauma. And then the remote location. It seems like a no-brainer, but when you break it down, there was a wide variety of locations that were defined as remote. Being in the mountains, such as desolation wilderness, being out in the desert, like being in Africa, the Pacific, maritime sort of circumstances. And all of these, except for jungle, are areas that we can find ourselves here in the United States as needing prolonged field care. And when we look at the US, there are actually 12.2 million people that are living in quote-unquote remote areas. And the USDA defines remote as living over an hour away from an area where you have 50,000 people or less. So, large swaths of the Midwest, certainly Alaska and parts of Hawaii, those all fit into this definition of remote where prolonged field care can potentially benefit our patients. When we looked at the injuries and the illnesses of those 54 patients, the vast majority of them were life-threatening in nature. So it was important that they get onto the next level of care as soon as possible. So they actually warranted evacuation. When we looked at the mechanism of injury, we found that over 2/3 of them were actually non-battle related in nature. So these were the falls, the MVCs, the things that didn't result from actual acts of war. So those are the injuries that we would expect to see in a civilian nature or the civilian environment. Unfortunately, as recent events have shown us, is that battlefield injuries are not necessarily exclusive to the battlefield. So the Prolonged Field Care Working Group was stood up in 2013, and a lot of it was revolved around getting special operators, special forces, to talk about this problem, because this is something that they had seen before. Prolonged field care had kind of gone out of vogue as we ended up with these robust systems that came in, and so they got together and said, well, we realized that we're not going to be able to have everything we want from a medical evacuation system all the time. So we need to prepare and equip ourselves for the future. The first lesson that they identified was that good first aid is good first aid. So the very first thing that the patient gets. And oftentimes, as we saw in our studies, that the first person that treats the patient isn't always a medic. This has been driven home time and time again with TCCC and the Rangers, because the Rangers went back and they looked at all their infield care. They looked at about 416 patients, and they couldn't identify a single one of them that died in the field because of a lack of something that they should have been doing. And a lot of that they attributed to the fact that every ranger, whether you're a medic or not, they get training in tactical combat casualty care. So everybody knows what to do, because invariably there's going to be instances where the medic is the one that gets shot. And that has also kind of morphed into the civilian side in the Stop the Bleed campaign. So here we are trying to enable and trying to empower every civilian within the US and abroad to be able to manage life-threatening hemorrhage through the application of tourniquets, through appropriate management with things like combat gauze and manual pressure. And that's a campaign that's just kicked off here in the last few years, and we'll see how that affects survival from these sort of injuries. And then they also had to remember is that prolonged field care is really pre-hospital care 401. This is not the basic level medicine. It's graduate level, and it really shouldn't be practiced or expected to be practiced by anybody without the appropriate training and experience. The good thing from the civilian side, though, is that local EMS protocols, they have these protocols, they have physician oversight. There is a model around which they can implement some of this prolonged field care material. Lesson number 2, involve the field care practitioners in every aspect of the development of a program. We know a lot about emergency medicine, surgery, critical care. What we don't know a lot about is being a medic in the middle of nowhere with no staff, no support, no hospital, no labs, radiology, all the things that we take for granted. And you're in a hostile environment, hostile not only to the patient, but potentially to the medic themselves, whether it's weather, whether it's enemy activities. But just realizing that the environment affects the capabilities and performance not only of the patient, the practitioner, but also your equipment. And then the third lesson was that the provider on the ground, by its very nature, will be overwhelmed. So it's within the definition of prolonged field care that you're working in a resource-constrained environment. You're never going to have everything that you need to do the job the way you would want to do it at stateside. The things that we can do to help this are to develop systems that model current practice. So we try and bring the civilian side of medicine to the military. And that's been done through a variety of references, such as the TMEPS, the SOFMED handbook, the Ranger handbook. But going forward, we need to augment and adjust these to include a component of prolonged field care, to include some verbiage about, okay, so say you've done this portion, you get to the point where you're taking care of the patient for 6 hours, now you need to start thinking about this. Clinical practice guidelines, these are being published on the Prolonged Field Care website and are being used to train and using it as existing technology. So smartphones, apps, you really, it's nice. We always want to say that we don't want to memorize everything, but we've all got our pocket brain with our smartphone, which tells us everything we need to know about meds and the things that you don't necessarily keep in your head all the time. And then teleconsultation. So this is an important factor. This really becomes a force multiplier because you're turning, whether it be the surgeon, the critical care doc, the ER doc, or even the flight surgeon, you're turning them into multiple people if you're able to use them to contact and be a call point for somebody who's down on the ground, they've got their patient there, and they want your input. A lot of these special operations medics, they can handle their own, they can do the job, but it's really, you get that nice warm fuzzy when somebody's on the other line and saying, hey, you're doing this right, or hey, maybe you should consider checking this. And then, but what does that take? That takes, you need to know how to call. So that requires technology, it requires training on how to relay medical information appropriately in a concise manner. And then who do you call? What is the system that's going to be set up in order to direct the calls to, say, the orthopedist or the burn surgeon? And within the military, there is a system for that, where anybody that calls in, they have a slew of specialists that are on call basically 24/7 to answer these sort of questions. But it may get to the point where you have teleconsultation, you can actually sit there and guide somebody through a procedure such as a fasciotomy. And in general, civilian EMS does this pretty well. There are published protocols. You can go to, for example, Tahoe or Sacramento. You can see what the EMS protocols, what they're allowed to do, what they're not allowed to do. But again, the resources, the ability to connect with a provider at another location may be compromised during a prolonged field care scenario. So then we'll talk about the solution. The working group initially put out 2 papers on prolonged field care, and those 2 papers you can see here. So what are the core critical capabilities of prolonged field care? What should you be training to? What should you know? And then the operational context of prolonged field care. Now, what I'll note on here is that both of the first authors on these papers are senior medics. So they're not physicians, they're not hardcore dedicated researchers. They are people that are doing the job day in and day out. And that was just the way of, and that's very common with all the Journal of Special Operations Medicine's paper. A lot of them require a medic level provider to be on those papers. And that's just going back to the idea that it's very important to incorporate and bring the medical providers that are going to be doing the work on the ground, bring them into the discussion. The prolonged field care capabilities you can see here, there's 10 that they identified. We'll go through each of the 10, and they're presented in a good, better, best. So kind of what's the minimum that you should be training to, what would add a little bit to that capability, and what would be considered the gold standard, like you can't do much better than that in the field. And this is all an idea so you can get to thinking about how are you going to train, how are you going to equip your men and women to do this job. So the first one, and it seems pretty basic, so just being able to monitor the patient, to identify vital signs, to look at trends. And the equipment that you need for this is really not that sophisticated. So simply having a blood pressure cuff, a stethoscope, pulse oximeter, a Foley catheter, which a lot of times we don't think about, but urine output is an extremely useful vital sign, or not vital sign, but a thing that you can trend. And then having a method to accurately document this so that you have a record that you can look at, you can identify a trend, and then in the end you can hand that over to somebody and they can see what you've done. Better would be to add capnography, and the best is having an actual vital signs monitor that can really take away from some of the tasks. So in a situation like this, you have multiple patients, you're going to become task saturated pretty quickly. And so having monitors that can actually record this and alert you when a blood pressure is a little bit too low, that can be really, really valuable. And some of the really nice monitors will actually provide this in a printed form or even forward it in electronic form to the next level of care. So monitors are very common for our EMS crew. This is not something that is brand new, but we have to realize that these may not be available if, for example, you're hoisting in to take care of a patient for a long period of time. And even if you did have a monitor, they rely on battery power and they may not last the length of time that you need. So the monitoring required equipment here, again, within this box, really not that expensive. So you can find most of these items on eBay or Amazon for well under $100 total. And so from an equipping standpoint, that's a very reasonable cost to say, hey, you're going to take this with you, make sure you use it, and then make sure you use it with a documentation format that's going to actually provide you some benefit. And that documentation, it's a little hard to read here, but anybody who's spent any time on the other side of the blood-brain barrier, this looks very familiar. So this looks like anesthesia sort of documentation. And what the prolonged field care working group has done, they've gone through multiple iterations of this, and they've slowly made it better and better, where you can document not only the time, but all the different vitals. It's got a checklist there on the right that tells you, kind of to remind you as the field care provider that, hey, I'm supposed to be doing something. Oh, I should consider putting in a Foley. It also gives you areas to document the GCS as well as any sort of drug interventions. And this is what one of those would look like if it was all filled in. And again, you can start to see how you would identify trends within the patient care. The backside of that same card has this information. So you can imagine if you got this sheet of paper, you could have all this filled out and you hand it over. And anybody who can read that and identify, this is exactly what you did for this patient. These were the injuries, and this is what we need to take care of going forward. And even at the bottom, there's this telemedicine call script. So for the person who doesn't necessarily make a whole lot of telephone calls to physicians, they can say, this is, I'm so-and-so, I've got this patient, this is what happened to them, and this is what I've done to treat that patient. Core capability number 2 is being able to resuscitate the patient beyond the typical crystalloid or colloid. This was seen as a vital capability within special operations, and they've gone through various iterations of using both freeze-dried plasma. A lot of the teams will deploy with actual packs of packed red blood cells. And in the case of the Rangers and Norsoff, they've actually gone to a whole blood program where you have a walking blood bank, where they've identified the members within their team that are the appropriate blood type, and they have a low titer. They get their titers checked on a regular basis so that they know, okay, if somebody gets hit, they immediately make a call based on this algorithm on the right side. They make a call and say, okay, we need to start procuring blood for this patient because we think they're going to need it. And there have definitely been lives saved because of this capability. Now, going back to the civilian sector, though, we're primarily using blood component therapy due to availability and quality control. But there are locations such as Pittsburgh, the Mayo Clinic, that they are actually working on using fresh whole blood in their trauma center. So it may only be a matter of time before this gets pushed out a little bit further forward. Being able to ventilate and oxygenate the patient, your basic would be having a BVM. Better would be to have some actual supplemental oxygen to go with that BVM, and then the ultimate would be to have a ventilator that can provide that supplemental oxygen, and you can kind of tweak and fine-tune things, especially if you're going to be taking care of somebody who's going to be intubated for a long period of time. But they can be difficult to transport and have a limited capacity and battery life. So once your oxygen is out, you can't really refill that. The same thing with the battery life. Core capability number 10, so being able to, you've got the ventilator squared away, but now you got to make sure that you've got some way of obtaining definitive access to the patient's airway. And so all the medics are trained to perform cricothyroidotomies. The better kind of version of that would be to say, okay, we can at least work on getting RSI capability up to snuff. So training to being able to use the paralytics to go through the P's of RSI. And the thing about transitioning that to a civilian institution is that these RSI protocols, they are out there. There are first responders that have this capability, but it's really not universal across the system, and it will vary from place to place depending on whether or not they can do that. But so there have been some studies that show that with about 1% of the time they can't get the airway. The rest of the time they actually do very well with RSI. Being able to use pain and medications to obtain both sedation and pain control, training in the use of ketamine, which again, ketamine protocol and availabilities are pretty variable across civilian institutions, but it's been widely used within the military. It's been very effective, and it's something that it's kind of hard to imagine deploying without the use of ketamine. The other things, the best would be to have actual experience with long-term sedation with some of those other adjuncts that you can see there with the morphine, Versed, fentanyl. Core capability number 6, being able to use both your physical exam and other diagnostic sort of modalities to gain awareness of the patient and figure out, is this patient tanking? So this can be as simple as, looking at the urine output and saying, okay, we need to tank this person back up. They're not perfusing their kidneys well enough to make urine, but expanding that beyond that to ultrasound, point of care, lab testing, where you have a little lab that'll give you your lactate, your CBC, your chem panel all in the palm of your hand. But even better than just having the equipment is actually knowing how to use it. So training with it and being experienced in its use. From a civilian standpoint, the ultrasound and the point of care lab testing, aside from point of care glucose, they really don't have a whole lot of capability within the back of an ambulance or on that you can throw in the ruck and take with you on a rescue mission. But it's not that it's impossible, it's just that implementation takes a lot of training and it takes a lot of money. Core capability number 7, so being able to provide things that we've kind of classically identified as nursing, but it's just really just good patient care. So keeping the patient comfortable, considering things like hygiene, at a minimum just keeping them warm, keeping them dry, padded, catheterized, and providing some basic wound care. And the better would be able to, again, being able to do wet to dry dressings and having experience in taking care of the patient. And these are all simple and low cost interventions, which really can have a tremendous impact on morbidity and mortality. Number 8, being able to perform advanced surgical interventions. So this is one of those things where a lot of times we kind of say, well, this is our job. It's our job to do the cric. We shouldn't be training people to do this, but being able to put chest tubes in and crics, those are fundamental to TCCC, or at least the cric is fundamental to TCCC and being able to manage that patient for a long period of time in the field. The better would be to add on to that being able to perform eschorotomies, fasciotomies, doing actual wound debridement, and in very rare cases, being able to perform a field amputation. And then the best is obviously having some experience with those and being able to do that at the drop of a hat. Those surgical skills, while they are crucial and they can be very important for morbidity and mortality for the patient, they're really not often tested or not really frequently practiced. So it's one of those things where you can get a model trainer to do crikes, but until you've actually done the crike on a human or some other model, it's again, it's just never the same. You wonder if your skills are going to be up to snuff. Number 9, perform telemedical or telemedicine consult. So making communications with the home station, wherever your doc is, or making contact with a specialist. It'd be even better to be able to transmit and provide them with some ultrasound findings or some lab findings that run of vitals that I mentioned earlier. And really the goal, what we'd like to see in the future would be actual video teleconference. Granted, there's a lot of technological barriers to that, and as far as quality of imaging and the ability to transmit large volumes of data. But if you had something that was high def that you could actually take somebody through and say, okay, cut there, don't cut there, spread there, you could conceivably take a field level medic and take them through a fairly sophisticated procedure. EMS, civilian EMS, is very well versed in just medical command and control. They always call back to the ER and say, do you have any additional orders? This is what we're bringing you. Do you want us to do anything else? So it's not very different from what we have in our current civilian institutions. The matter is just expanding that to where you're now 100 miles away from the patient instead of just being, a radio call in. And then the final one is to prepare the patient for flight. So at a minimum, we need to be familiar with the physiologic stressors of flight. Notice the cold, the drop in oxygen tension, the vibration. These are all critical things when you're going to take care of the patient in flight. And they're skills that it's a fairly unique skill set, and it's really only taught to flight nurses. The second paper dealt with the operational context of prolonged field care, and to sum this up, it really is just realizing that you're not going to be doing the same exact thing in every phase of care. You're not going to go through the steps 1, 2, 3. You may end up like our previous example, where you end up spending some time in the back of an aircraft, and then you transition to a building that's not a hospital, and then you're back in an aircraft, and then you're in a truck, and then you're back walking. So you have to be able to transition through all those different phases and realize that you really have a difference. There's going to be changes along the way that you need to make. And they summed it up with the trains, planes, and automobiles. And if you've never actually seen the movie, it was pretty comical that the amount of work that they had to do just to go from point A to point B. This is what they planned to do, but this is what they ended up doing. And that's a lot of what these prolonged field care circumstances will look like. If you have a chance, watch this movie. It's good for the Thanksgiving holiday, and it'll give you a much better appreciation for some of the modern conveniences such as Uber and cell phones. Operational context, so within prolonged field care, so instead of using planes, trains, and automobiles, we used ruck, truck, house, plane. And so the ruck being what you're carrying to the farthest point of the mission on your person, the truck being the conveyance that gets you the house, or that gets you there, the house being some sort of structure, kind of a team house where you're keeping all your additional medical equipment, and then the plane being really any aviation asset that you can call for or commandeer. Again, they won't be sequential, and for the military medical personnel, we really transition through all those levels of care with the patient. Occasionally we'll do a handoff, but in most cases you're expected to be able to transition with the patient. And that's really quite starkly different from our civilian circumstance, because I can't imagine our flight nurses accepting you as a provider on their aircraft. From the EMS standpoint, a lot of these are very similar. So whatever you're taking out to the field, a good example of this would be for the ski patrollers. You have whatever you're carrying on your person, you have whatever you have in maybe your snowcat or on your snowmobile, you have whatever is in your chalet or your ski house, and then you have the aircraft that will take you to the next level. An example just from the ventilation side of things, you would be expected to be able to carry a BVM in your ruck. You might have some oxygen bottles in your truck. In your house, you've got a ventilator, and on the plane, you can combine all those and get the patient what they need. So let's tie this all up and incorporate this into civilian practice. So from a training standpoint, you have to remember that it's not really a qualification or a skill set. We don't expect there to be a prolonged field care card that you carry in your back pocket and say, I'm certified to do this. It's more of an operational problem or a situation that you find yourself in that you have to then work around. Using the ruck, truck, house, plane model to focus when you're training is going to be very important. Like just to constantly ask yourself the question, if I had to hang on to this patient for another 6 hours, how would I manage them differently? What would I do? And then being able to use the resources that are available on a variety of websites in order to augment training. Equipping, so the limited resources is that defining feature of prolonged field care. The equipment that you decide to bring with you or that you decide to purchase needs to be lightweight, compact, durable. Durable not only from being dropped, but also from a water resistance standpoint, dust, shock, altitude. And ideally that equipment is multi-purpose so that you can carry one thing in your hand that does, maybe it does your monitoring, but it's also your ultrasound. But in the end, you can spend a ton of money on equipment. The Air Force and the military does in general, but the technology is not a suitable replacement for provider knowledge and experience. If you don't know what to do with that piece of equipment or you don't know how to interpret what it's telling you, it's going to be all for naught. And then just anticipation and planning. So this goes into both local disaster planning, but if you're the medical director of an EMS system, how do you want to incorporate this? Is this something that's not important to you because you're in a large population center? Maybe if you're out in the rural areas, this becomes more of an issue. But even things like adverse weather, natural disasters, terrorist attacks, mechanical issues, remote locations, these all impact the time that it takes to evacuate a patient and the availability of medical resources. So in conclusion, prolonged field care has proven within the last few years, and even going back further than that, to be a vital subset of military medicine. I'm glad to see that there's been this resurgence of interest in this topic. It has been utilized in civilian search and rescue, and I'm sure there's tons of anecdotal stories about how we've already been doing this, but I would argue that there's not been a whole lot of training focused on actually making this a common thing. Has a lot of similarities to wilderness and global medicine. It really does not have to require expensive training or sophisticated equipment. It's promoted and supported by a very robust website and a working group that is constantly working on making this better, and it will continue to evolve and improve with the experience. If you're interested in finding out more, pfcare.org is the website you can go to. There was also a really nice supplement recently in Wilderness Environmental Medicine, where they basically, the entire volume is all about transitioning and taking a lot of the lessons we've learned in combat for the last 15 years and transitioning them to other austere environments. And I would just argue that sometimes, regular civilian life like we imagine today has the potential to become an austere environment. And then with that, I'd just like to thank Colonel Sean Keenan. He's kind of one of the heads within the working group for providing me some slides that I could adapt to this. So I'll take any questions you got. Ma'am?
Great talk. So I think when most listen to this, I think it's all going to be battle-related injury, and you're going to have the same equipment. And I think what struck me is when you showed that picture of what you have in the field, and then kind of those MASH units are not there anymore. Mm-hmm. So you're going from the field to the hospital, so that takes time. Right. And with kind of 30%, and what you showed, and medical injuries, other injuries, or medical issues, medical injuries, or non-traumatic injuries and traumatic injuries. How do you plan? I mean, that seems like you need a lot of equipment. It's not like you have a shiny ambulance that has the nitro and the ET tube and then everything for trauma and the ball cord and the C collars. How do you possibly know what to have with you, or do you dispatch those things and take what you need depending on the case? Yeah.
Fortunately, within the military, a lot of those, what we call UTCs or unit type codes, they're an entire slew of medical equipment. It includes not only the equipment and the personnel, But they've done a lot of thinking about, what is the minimum that we have to take, and if we had, for example, a mass casualty circumstance, what are we expecting to need as far as fluids, tourniquets, litters, that sort of thing. I agree, it is a problem when you start looking at the non-TCCC sort of events. If you tried to create a handbook that covered everything, again, that handbook would be too big to put inside the ruck. So I think that from an education standpoint or from a information standpoint, having access to portable electronic things like a smartphone that can be loaded with all that information where you can then reference, I think that using that along with some algorithms are really going to help our medics in the future because they won't have to necessarily have this entire fund of knowledge. They'll have something that they can reference. But again, there's issues with references as well. How functional are they? How quickly can you get the information? And are they durable enough to withstand the rigors of being in the battle space? So it's one of those things where I think by doing some of this research where we've looked at prolonged field care, we've looked at what those patients need. Going forward, if we continue to record that data, we're going to have a better idea of what the prolonged field care patient looks like. And we'll be able to better kind of cater to their needs. And there was plenty of things that came out of this study that it had an entire section where it was literally just, tell us what you felt worked, what didn't work, what other needs did you have? And a lot of the best data from that came in that form, where it literally it's okay, battery power was an issue. Well, it seems like a no-brainer, but it's one of those things that's very important to remember. Training the people around you to do the same thing that the medic does, again, came out of that as a very important training sort of directive. Yeah.
Great talk. A lot of us are obviously out hiking and doing all that kind of stuff, and doing the role where we become the first responder. Mm-hmm. Often, if you don't have the right equipment, you just feel like there's nothing you can do. Are there any kits that you know of that meet the criteria for you to be an advanced first responder that you sort of get ready-made, or do you really have to sort of put it together yourself?
I think that there's plenty of companies out there that are supplying, kind of ready-made kits that have, for example, SAM splints, a couple things to treat bleeding. You can certainly buy that, but I would recommend that if you do a lot of hiking, you're interested in that, take the Advanced Wilderness Life Support course. It's an excellent course from the standpoint of you learn how to use the equipment that you're taking there, but you also figure out how to pack your own, and you figure out what you're going to need, and not only what you need, but what you can improvise. Instead of having an actual splint, being able to use a walking stick. That sort of thing is I found very useful in that course when I took it, and it's one of those things where you can then develop your own kit. But yeah, I'm sure you can go on. There's a variety of places like North American Rescue is one that just pops to my mind as being one that they sell a lot of prefab, pre-organized kits, and there's a lot of companies like that though.
I just noticed like one of the things you had was an O2 sat monitor. Mm-hmm. I mean, I'm sure a lot of the kits don't sell it.
Probably not, but that's something where if you were to take a course or just realize what you're going to need in the field, you can identify that as being a shortfall, pop it in your ruck, and those things are very good from a battery life standpoint. They'll provide you obviously with the pulse in addition to the oxygen saturation. And in the absence of an actual monitor where you're getting EKG tracings and capnography, if you had nothing else, that would provide you a ton of information.
Great talk. I was wondering if you know if there's any similar information about epidemiology on the civilian side, similar to the study that you guys did?
Not that I'm aware of. A lot of these sort of instances or these events are kind of just squirreled away in the minds and the memories of the people that took part in them. So for this particular study, it's not like we had these all written down somewhere and somebody had to just go look through them. We had to basically put out surveys and say, do you remember taking care of anybody that you had for more than 4 hours? 4 hours was a pretty arbitrary timeline cutoff, but we had to, imagine in our minds that nobody in their right mind would take care of, a patient for 4 hours or more if they didn't have to, at least not the medics. So, even in that case, we were relying on the memories, some of the after action reports that had been written down, but it's just that information is not stored anywhere in any large database, and to some degree, I think it should be. because I think we can, going forward, identify those and say, hey, if you have a mission that's longer than 2 hours or something you would classify as prolonged field care, why don't you just write it down and let's put it in a repository somewhere where we can kind of monitor these and see where they're going. Because they're happening all the time. The pararescue out in I think they're out in the Atlantic, they had a case recently where they saved 2 burn victims off a ship, and it may have been the first time where they performed escharotomies, as medics, which, that's great. We want to hear about that, but we also need to record that and kind of think about what that means for the future as far as training. Because a lot of people would say, well, you don't need to know about escharotomies. Well, these guys did. Dr. Gingrich?
Great talk, and thank you for putting together for us. Sort of continuing on Charles' question, how do you see this changing the training for the medics and the soldiers going forward? When I was in, the recruiters were looking for more quantity over quality. Certainly hurts outcomes in this sort of situation.
Right.
Where do you see that?
Well, right now, a lot of this training is, so where's this training going to go? So a lot of this training right now is kind of focused on the special operations units. So those generally tend to be the more well-funded units within any sort of branch. So I think it's going to, kind of grow from there until the point where we realize, okay, even our regular medics, they need to have this information as well. The nice thing is, again, this is all open access. You can go to this website and and pull this off. So anybody, literally anybody, can go on and pull off the information, pull the clinical practice guidelines. There's an entire podcast that goes along with it, and they can get the information. So the training is out there. As far as when it's going to become an actual directive, it says, okay, everybody who wears the medic badge needs to have this information. I think for right now, it's probably going to remain with the Special Operations Forces, because those are the ones that are getting flung kind of far forward and that have more of a need. But I can see in the future, depending on where we end up, that this becomes just a part, not necessarily a footnote, but an extra chapter within the medical training that, you also have to consider this prolonged field care stuff. All right. Thank you very much.